Sylvania, and Wadley. And from the Albany Area Primary Healthcare Centers, Lee Medical Arts. I'm not sure if there's anyone here from Dawson or Edison. And if there's anyone here from the Phoebe Family Medicine Residency Program, if no one's here today, we expect that they will be joining us soon. We're very happy to be expanding. And welcome to all of our TeleDerm team members, our dermatologists, Dr. Loretta Davis, Dr. Harold Rabinovitz, Dr. Buchanan, and there may be some dermatology residents out there and medical students. And then here in our hub room, we have Kenza Mamuni at the controls and Brenda Santiano. Now, Kenza will be leaving soon for maternity leave. So we want to thank our two newer hub members, Mosh Rara and Mohammed Siam, who will be taking over Kenza's duties here while she is off. And then I know we do have some medical students. Mackenzie Maloney is out there in Cyberland. I'm not sure if any of our other medical students are there who work on the TeleDerm. So please remember to put in the chat your full name, your email address, and your clinic affiliation. I think many of you have already done that. So there are samples in the chat. And I will review our agenda for today. So we start out as usual with our introduction. We'll have our didactic session, which will be given by Dr. Margaret Newsome, who's a dermatology resident. And then we will have our case presentation by Chandler Johnson, one of our fourth-year medical students. Let's see, what is next? I guess now is the time that I can turn things over to Dr. Buchanan, who will continue talking a little bit about Project ECHO, and then she will go on to introduce our speaker for the day. So, Dr. Buchanan.
Hi, everyone. So we'll go ahead and move right along today. So again, we're doing our Project ECHO session, and today we're going to start like we always do with a few announcements. Next slide. So we want to improve knowledge by telemedicine at the local level and use distance learning approaches to help dissolve the dermatologic health disparities faced by people living in rural areas in the state of Georgia. Next slide. And so these are just a few general reminders for today. All these sessions are recorded. And so by participating, you are giving your consent to be recorded. And then please do not mention any PHI in any of our discussions. And when we get to the end of the presentation, we'll give the number for CME and the code that you need to type in to receive that. And if you have any questions, you can email us below. Next slide. Yes, and so general reminders. I know we like to black out our video from time to time, but if you could today, just leave it open. We want to see everyone's faces, and just remember when you ask a question, unmute yourself and then mute yourself back after you ask your question. If you have questions, you can raise your hand, you can type it into the chat, and just a reminder to introduce yourself whenever you speak. Okay? So if you have any problems when we're presenting, you can email Kenza or use the chat. And so I would like to introduce Dr. Margaret Newsome. She'll be doing the presentation for today. Rashes are not my expertise. Maybe they were at one point, but I'm very excited for her to present today, and hopefully we can all learn something. So I will let Dr. Newsome share her screen now.
Thank you, Dr. Buchanan. All right, let me see. Are you guys seeing my screen?
We are.
Okay, so I'll just launch right into it. So my name is Maggie Newsome. I'm one of the dermatology residents here at MCG, and excited to present to you guys today about some, not all, of the common viral xanthems. It was hard to pick which ones to go over because there are just so many, but hopefully the ones today that we're going to review will be helpful and useful to everybody watching. So I wanted to start with pityriasis rosea. So this is a very common kind of self-limited eruption thought to be due to human herpes virus. This is clinically characterized by scaly red patches. So scaly erythematous kind of oval shaped patches, which we'll go over some photos in a minute. And let's see. So what a lot of us probably remember from our training is that this is classically preceded by what's known as a herald patch. So it heralds the beginning of the rash. So it can be days or up to a week or two prior to the rest of the rash. It's usually an oval shape and usually larger than other lesions. The history of this lesion, it's typically on the trunk or proximal extremities, and it can grow in size after it first appears before the rest of the rash erupts. So we'll look at some photos of that in a minute. Most patients say that the rash is completely asymptomatic, not itchy, not painful, but there is a subset of patients that will complain of itching and pruritus. So we'll talk about ways to manage that in a minute. What's really key about this is just reassuring the patient that this is self-limited. It will resolve on its own. It's important to tell them that this can take 6 to 8 weeks to fully resolve, because if you tell them it will go away and a few weeks later it's still there, they might be upset or concerned, but just reassuring that this can take a few months, sometimes even more than 8 weeks to fully go away. And the reason this is on the common viral rashes lecture is this is thought to be due to human herpes virus, which is a DNA virus. And interestingly, not only the virus, but certain medications and even vaccines have been linked to an identical eruption to what we're about to look at. So one of my, one of the patients we saw in clinic earlier this year actually did get this eruption shortly after getting a COVID booster. So vaccines and medicines can also cause this eruption as well. So diving into clinically what it looks like. So classically, we get these erythematous, which just means this bright red, oval shaped patches or plaques that are oriented with their long axis along Langer's lines. Now, what we mean by Langer's lines are those folds that you can see in the skin with this zoomed in close look. We all have these just natural folds and creases in the skin. And you can see that the long axis of these ovals are oriented along the same as the skin creases or the Langer's lines. They also classically have what's called a trailing scale, which I'm going to highlight with an animation in a minute. It just means that the red border, that if you had your eyes closed, you'd be able to feel that border there. It's a raised border, and the scale is inside of it. So it's not a leading scale, which would be farther out from the red, but it's classically inside the red you can see there. And the scale also, I thought it was interesting when I was doing some reading that it classically points inward towards the center of the lesion, which you can appreciate here. And in skin of color, it's important to note that, as with all other rashes in skin of color, the erythema can be a little more difficult to appreciate. So sometimes it takes a little bit more just looking for those subtle clues that you can see this what we call papulosquamous, just meaning red and scaly kind of patch or plaque that is an oval in shape. Like I said before, classically on the trunk or proximal extremities and oriented with the long axis along the skin cleavage lines. So this little animation I put in here to show you guys what I mean by trailing scale. So you can see that the raised erythema, the red border, is actually beyond that scale there. So that's classic for PR. Okay. Here's just some other photos, trunk and proximal extremities. And then that photo on the right, you can see that herald patch that days or weeks before the rest of the rash would have preceded everything, classically larger, and can kind of grow in size before the rest of the rash erupts. So it's very common. So when you see these patients, lots of reassurance that it's self-limited with, like we said, within 6 to 8 weeks, it will go away on its own. You certainly don't have to do anything. If they are having severe symptoms, a subset, like we mentioned, would be very itchy. You can use topical steroids. It would be probably our first line agent to use to manage itching. If it's really severe, you can use phototherapy or oral antihistamines. And interestingly, what the latest research shows, due to this being thought to be due to a herpes virus, you can use acyclovir. There was a study looking at almost 90 patients showing that 75% of those that got acyclovir had complete clearance within 2 weeks compared to 0% that were on placebo. In our clinic, we like to use valacyclovir instead, or Valtrex, because it's twice a day dosing instead of 5 times a day. And we find that that works very well. There is also some evidence for erythromycin, kind of similar stats to acyclovir, that 3/4 had complete clearance on oral erythromycin after 2 weeks compared to none in the placebo group. So that's thought to be due to a significant number of patients complaining of upper respiratory infectious symptoms prior to the onset of the rash. And also, like we mentioned, keeping in mind drugs or vaccines as a cause as well. Okay. So moving on to one of the enterovirus infections that's common, and I think been going around this fall a little bit, hand, foot, and mouth disease. This is also a viral exanthem that is acute and self-limited, a little bit shorter duration than PR, like we were just talking about, more like a week to a week and a half. Classically, we all learned in training that this is caused by Coxsackie A16 virus. It's important to note that this is highly contagious and transmitted through fecal-oral transmission, predominantly in daycare centers or nurseries. So a lot more common to see this in children and kids. They might have prodromal symptoms. Some kids will have fever, kind of just generally feeling achy and not feeling well, and sometimes GI symptoms like diarrhea or vomiting. In general, unless the symptoms are severe, just supportive treatment, symptomatic treatment, and it will resolve on its own. So clinically, just like the disease is named, you're going to see lesions on the hands, feet, and mouth. You don't necessarily have to see all three to make the diagnosis, but classically, you'll see these pustules or vesicles, so these little fluid-filled blisters on the palmar and plantar aspects of the hands and feet. They can be on the dorsal sides, meaning the tops of the hands or feet, but more classically on the palms and soles. And then, like you see on the picture on the right, the mucous membranes of the mouth can have these little fluid-filled vesicles and pustules as well. Okay. There's just a closer look at somebody with some pustules on the plantar aspect of the feet. So something that's really interesting to note, even though this is typically a pretty minor self-limited disease, it is important to note that kids with eczema or atopic dermatitis do have a disrupted skin barrier. So their skin is not fully functional like other patients to block viral contact with virus. So they can have a more widespread distribution that's not just limited to the hands and feet. And this is called eczema coxsackium, not totally different from what some of us may have heard, eczema herpeticum, when you have herpes virus kind of take advantage of that disrupted skin barrier. So something to keep in mind for our kids with eczema, they're more susceptible to more diffuse involvement. And something more specific about hand, foot, and mouth disease that we thought was worth mentioning is really in the last decade, and especially the last several years, there has been an outbreak of what's known as atypical hand, foot, and mouth. Instead of being due to Coxsackie A16, it's more commonly due to Coxsackie A6. They think that this is becoming more of an issue just because of the virus mutating and evolving over the years. So really only since the last 10 years or so has this been reported, but I'll just briefly go over the different presentations because it can clinically mimic many other entities. So this is a report from this year that went over, reviewed many of the cases that are out there. So these photos here show that you just get these red kind of papules on the extremities, the dorsal extremities, the legs, the arms, as well as the cheeks. So this can really mimic something known as Giannotti-Crosty syndrome, which is a another viral rash in kids. And just something to keep in mind of differentiating the two is this, just like classic hand, foot, and mouth, you're more likely to have involvement of the palm soles and oral mucous membranes. As long as the patients are stable and, you know, you're supporting symptomatically, differentiating the two, they both are self-limited viral outbreaks, but definitely important to look for those subtle clues to help differentiate. So here you can see that you've got more kind of eczematous, crusted kind of lesions in the groin, but once again, you're going to differentiate this from other things that this could be from the involvement of the palms and soles, which a classic atopic dermatitis would not be as common to involve the palms and soles. So this is the atypical hand, foot, and mouth. Likewise, you can get more petechial purpuric lesions that look more like bleeding under the skin, could start to think about certain kinds of vasculitis, vasculopathies, but just keeping in mind that with the involvement of the palms, soles, mucous membranes, and the buttocks as well, all can point to possible hand, foot, and mouth. And lastly, you can get these this vesicobullous presentation where it's more like blisters that have fluid in them. So if you ever have somebody that you think might be this atypical presentation of hand, foot, and mouth, you actually can do serum testing for enterovirus to confirm your suspicion, just to help you differentiate this from more common things. So moving on to something that we've all seen a good bit of, it's pretty common, especially in kids, molluscum. So this is also spread by direct contact. This is a DNA pox virus that, since it, just like herpes, because it's spread by direct contact, if you do have a child with lesions in the genital area, it does not necessarily mean any kind of abuse, but it's just something to put your antenna up just to be mindful of that. It can be spread through, if they have lesions in other areas and then they scratch, that can be a way that that gets spread as well. Something that's really important about the history of the lesions with molluscum is that they can last for months to years before they resolve on their own. So that's just important to know when reassuring parents that it is normal for these to last for a long time before they go away. But with a child with a healthy immune system, they will go away on their own. So just really important for reassuring parents. Clinically, what molluscum looks like are these papules that can pop up anywhere on the body where the direct contact has spread the DNA virus. They classically have this central, what we call umbilication, so just a little dimple in the center that commonly has this keratotic plug. So it almost looks like kind of dried, dead skin in the center there. So I've kind of drawn an arrow to that here. So on first glance, these might look a little bit like warts. So just doing a little bit of a closer look to see that central dimple and those that kind of keratotic core there. And you can see here how on first glance, they can almost look a little bit more like pustules. So if you just glanced quickly at that picture on the left, might be tempted to think they were bug bites or ant bites, something like that. But then you can see kind of that keratotic core as well as the central dimpling. And I have as well as the photo on the right, I have an arrow pointing to that central dimple. So since this is so common, we're going to kind of need to know some tips about the best way to manage it. The main point, especially for disseminated lesions kind of all over the body in younger kids, treatment is optional. So just reassuring mom and dad that you do not have to do anything. Some of the treatments can be uncomfortable or even painful for kiddos. So a lot of times, if they are younger or if there are a lot of lesions, we will just recommend just watching and waiting and reassuring them that their immune system will eventually clear it, but that it can take some time, like we mentioned earlier. As far as if they do really want treatment, or if a patient is a little bit older and able to kind of understand going through a little bit of an uncomfortable procedure, the options are very similar to how you would treat viral warts. So you can treat with cryotherapy, curettage, cantharidin, which is the blister beetle juice, you just topically apply, and a few hours later tell them to wash it off. And it forms a blister on the skin, which can be a little uncomfortable, but helps kind of remove that top layer of skin and get rid of that virus. And then there's, of course, intralesional injections, Candida, MMR, and vitamin D. Interestingly, there's some evidence, just like for warts, that oral cimetidine which can come in a liquid formulation for kids, can help as well. So if you had a patient with more widespread lesions that was younger and mom and dad really wanted to do something about it, but didn't want anything that would put the patient through discomfort or pain, this would be a good option. I was trying to read a little bit about the suspected mechanism of how this works, and it's thought that histamine plays a little bit of a role in immunosuppression. So when you're blocking that H2 response, your immune system is better able to fight off the virus. So there's some good evidence there. Now, we've talked a little bit about kind of HSV when talking about the differential for other things. So this is just such a common thing, herpes simplex virus 1 and 2, that you see commonly around the mouth, more commonly known as cold sores or fever blisters, things like that. And then also, of course, genital herpes as well. So common that it bears reviewing. What's classic about the lesions in herpes is that they're grouped. They're not going to be individual lesions, but they're going to be clustered together. They can manifest as vesicles, so clear fluid-filled blisters, pustules that have more of that white cloudy pus, or even if they've been scratched off or broken, just kind of crust, dried serum crust. So like we mentioned, particularly around the mouth or the genitals, and we'll kind of go over that classic scalloped border that helps to differentiate from other common things like just aphthous ulcers in the mouth. And then another differentiating factor is that they have this prodromal burning or tingling sensation before an outbreak. So a lot of patients that have had this going on for months or years can tell when they're about to have an outbreak because the skin starts to tingle in that area. And as we know, is highly contagious, spread by direct contact. Okay, so here are some examples of oral HSV, which is classically caused by HSV1, although it can be caused by other subtypes as well. So you can see anywhere in the oral mucosa, you can get these lesions that look similar to aphthous ulcers, but classically they have this scalloped border. So I apologize for my animations. This is my best attempt to kind of draw out that scalloped border just to show the difference between an aphthous ulcer would be more of an oval shape and wouldn't have that kind of notched border there. And same thing for genital lesions. You can appreciate kind of at this point, the vesicles have been scratched off, but you can still see that scalloped border. And it's important to note that HSV is not only penile and vulvar lesions, but it does love just that superior portion of the gluteal cleft. So really looking if you see vesicles or erosions in that area, looking for that scalloped border can help you make the diagnosis. So similar earlier to eczema coxsackium, you can also get an eczema herpeticum pretty commonly. So since it is a virus spread by direct contact, kiddos with and adults with atopic dermatitis who have that impaired skin barrier are at an increased risk for this type of infection as well. Over top of their kind of dried out xerotic skin, you'll see these punched out kind of erosions that you can see here, kind of grouped together, and that is a clue that this is eczema herpeticum, and so therefore they need treatment, antiviral treatment as well as treatment for their eczema. Okay, so it is important to start, just like with shingles, HSV, it's also important to start it as soon as symptoms arise, because after about 3 days, the treatment is going to be less effective. So once patients have a diagnosis, they a lot of times are able to tell when an outbreak is about to start. And so you tell them that as soon as they start to get that tingling sensation, they don't wait until they see something on their skin, but they go ahead and start their antiviral. And there are many different dosing regimens that I won't go over the specifics of each one today, but depending on if it's their first time ever having an outbreak of cold sores or genital herpes, or if it's a recurrent outbreak or suppression therapy, we generally will start to consider offering suppression therapy in our clinic if they've had more than about 5 or 6 outbreaks in a year. And that's something that they would take every day to reduce the risk of recurrence or severity of outbreaks. Okay. So moving on to another very common viral outbreak that we're all pretty familiar with, herpes zoster, more commonly known as shingles, which is due to that varicella virus that patients that had chickenpox as a kid will potentially be at risk of developing shingles later in life. This is something that we classically think of as that you see in older adults, but more and more commonly, we do see it in younger patient populations, especially those that are on immunosuppressive therapy. So something to keep in mind if your patients are on any sort of immunomodulating therapy, which we use a lot in dermatology. they will potentially be at an increased risk even at a younger age. So a lot of us know that as we all know, this virus hangs out in the dorsal root ganglia, which is why, and that's the dermatomal distribution. You see the picture on the right. What that means, dermatomes are groups of on the skin, or a map of the skin that are each innervated by certain dorsal root ganglia in the spinal cord. And so since that's where the virus hangs out and hides, waiting for an episode of stress or anything that would cause immunosuppression for the outbreak to then occur, that's why it continues to come back up in the same dermatome. So if someone had a rash in the C5 dermatome, then each time they get the outbreak, it will likely come back up in the same spot. So, and we'll kind of go over what those dermatomal rashes look like, but it comes up as papules, vesicles, or plaques. Something that's really important to know that can be dangerous, because usually this is self-limited and can reassure patients that it will get better and calm down on its own. But if it does involve anywhere near the eye, an urgent ophthalmology referral is important, just because it can rarely cause permanent corneal scarring and permanent vision loss. So something that is called the Hutchinson sign is if you start to get anything in the trigeminal division of the facial nerve, you will get little vesicles up on the tip of the nose, and that's called the Hutchinson sign, which means you're likely going to be getting some eye involvement. So anything that you suspect to be shingles near the eye, or anything that you suspect to be shingles on the tip of the nose, definitely consider an urgent ophtho referral. And then a lot of us have family members and friends that have suffered from post-herpetic neuralgia. So it's this severe pain that can reside for months and for a long time, even after the cutaneous findings have completely resolved. So we'll talk about some management strategies for that in a minute. Clinically, this is the dermatomal rash that we mentioned earlier, where you get these papules, vesicles, sometimes pustules, and it almost looks like a paintbrush was taken and kind of swiped across the patient. It's just in this linear array, because that is where that is where the nerve that their particular outbreak resides. That's the part of the skin that nerve innervates for sensory input. So you can kind of see two different presentations there. I thought it was interesting that if you zoom in closer to the lesions, they can look a little umbilicated and a little pustular. So at first glance might confuse with something like what we talked about earlier, molluscum, but important to note that they are full of fluid. They are vesicles, they are not papules, so they're not solid. So you can see the central umbilication, but that does not mean that it's molluscum. And then on the right, certainly could confuse some pain and erythema around the eye with preseptal cellulitis or some other entity that is not zoster, but then you see this vesicle here, or kind of a pustule. That would be your clue. Definitely an urgent ophtho referral would be needed in that case. Okay. So thankfully, we have a very effective shingles vaccine out now, Shingrix, which, unlike Zostavax, the old one, it is a recombinant vaccine and not a live vaccine. So safe to use even with folks that are on immunosuppressive therapy or just have immunosuppression for whatever reason. It is a 2-dose vaccine that I believe is approved for folks 50 and older, but hoping that will be a little bit of wiggle room in the future, just because, like we said, we've been seeing a lot of people getting this younger, especially those on immunomodulating medicines. So very effective vaccine, takes 2 shots. And then same as the treatment for HSV, you're going to start your Valtrex as soon as you can, as soon as they start to have symptoms, and it will hopefully reduce the severity and duration of the cutaneous rash. For post-herpetic neuralgia, you're going to approach that very similarly to how you would approach any kind of neuropathic pain. So just for mild cases, you can use topical capsaicin, which is the component that is found in hot chili peppers. And it's thought that the pain of the topical capsaicin actually depletes the substance P that's there. So in a way, it's like, giving the patient a little bit of pain to take away the pain from something else, kind of like a distraction there. So not sure, it'd be worth trying for sure. And then topical lidocaine, which is in things like preparation H for hemorrhoids, and you can find that over the counter. For more severe pain or more persisting pain, could certainly try gabapentin or pregabalin, as well as tricyclic antidepressants like amitriptyline, or SNRIs like duloxetine or venlafaxine. Anything past that would potentially consider a referral to pain management. Okay. So moving on to another DNA virus, parvovirus B19. So this is transmitted through respiratory droplets and less commonly direct contact. Classically, the most common, this can show several different skin findings, but the most common is erythema infectiosum, which we know as fifth disease or slapped cheek syndrome. And we'll see in a minute why it's referred to as slapped cheek syndrome. And then it can also cause something called papular purpuric gloves and sock syndrome. So the slapped cheek syndrome is more commonly seen in kids, and then the purpuric papular gloves and socks is more common in adolescents and adults. And we'll look at photos of both of those. So with the slapped cheeks, the patient gets this parvovirus infection. They might have prodromal symptoms, kind of fever, achiness, typical viral symptoms, maybe some joint pain. And then they get this erythema on the cheeks that spares the nose. And this is why they call it slapped cheeks. You can almost envision kind of a handprint on each cheek there. And I think that also helps me remember that it's fifth disease because there's 5 fingers on a hand. Okay. And then sometimes a few hours or days after the onset of the facial rash, they will classically get this, what we call reticular, lacy, or net-like rash on the trunk. And so that is what is pictured on the right. And I tried to do some animations to kind of show you why it's referred to as net-like. So you can see kind of these, this erythematous rash with these central clearings that, if you use your imagination, sort of looks like a net. So that is classically what will come after a few hours or days after the facial erythema and on the cheeks. So that was for kids. For adolescents and adults, like we mentioned, they're more likely to get this papular purpuric gloves and socks syndrome. Same as kids, they might have prodromal symptoms, but then they're going to get this like erythematous purpuric rash on the palms and soles of the feet, more classically associated with arthralgia. It's important to know for parvovirus, it's normally a self-limited eruption that you just treat symptomatically, but there are certain populations that are a little bit vulnerable. For example, pregnant women, it's important to keep an eye on them in consultation with their OB, because the fetus is at an increased risk of fetal demise and other fetal complications. This virus does like to go after erythrocyte precursors, which is part of the reason that it causes thrombocytopenia, both in healthy patients as well as moms and fetuses. And so definitely keep a close eye on your pregnant patients that have this, as well as those with sickle cell anemia are at increased risk of aplastic crisis. So the last thing I'll end on today, the morbilliform rash is something that could be a whole lecture in and of itself. Morbilliform just means measles-like, looks like measles. So maculopapular, meaning these red flat spots that you wouldn't be able to feel with your eyes closed, as well as these papules, these raised lesions that you would be able to feel if your eyes were closed. So I'm just going to go over some general what they look like and general principles to approach someone with a morbilliform rash. So like we mentioned, this just means resembling measles or maculopapular. So kind of just big overarching themes is if you have a child or a pediatric patient presenting this way, you're thinking virus or infection, whereas if you have an adult, you're thinking it's medication induced. Of course, these are not hard and fast rules. It's not always the case, but just kind of general principles and rules of thumb. And then I'll show you some photos afterwards of urticaria, which is the medical term for hives, that there's some ways you can differentiate those from each other because they can look similar. So on the left, you can see a pediatric patient that has this morbilliform rash. So this widespread red rash, might burn, might be itchy, might be asymptomatic. And you can just imagine that if you closed your eyes, you could feel some of those lesions. And on the right is an adult with a very similar looking rash, but because one is a child and one is an adult, most likely the child is due to an infection and the adult is due to an offending drug. So doing a thorough medication history is very important. Now, how to differentiate this from diffuse hives or urticaria, because as you can see here, especially that slide or that picture on the left, these can look very similar. So, and maculopapular rashes, just like hives, can be itchy. So one thing that I think is helpful textbook in the textbook, and it's true in real life, if you circle a specific individual lesion and it's still there 24 hours later, then it's more likely morbilliform, whereas urticaria and hives, individual lesions, not necessarily the rash as a whole, but individual lesions will disappear within 24 hours. So that is one way to differentiate. That can be tough when you have cases on the right where they're more confluent, more generalized rash, not a lot of individual lesions. And so something that in both these photos can help you to know that this is urticaria or hives and not a morbilliform rash is this central clearing of lesions, which you don't see with morbilliform rashes. So you kind of get this like pallor in the center of the wheal or the hive there. So that is all I have for today. So thank y'all for your attention. It's hard to decide what to present on today because there's so many viral rashes and we had limited time, but let me stop my screen sharing and then we can let me know if anybody has any questions.
Thank you, Dr. Newsome. That was very impressive. I think, you know, as dermatologists and residents, we spend a ton of time like learning about primary morphology. And I thought Dr. Newsome did an excellent job describing the different features of these, you know, viral rashes and viral exanthems, because really, if you can clinically recognize it, that's usually the first step in getting the patient the appropriate treatment and also preventing things like unnecessary biopsies when possible. So great job. I would just encourage everyone, you know, if you have any questions about the morphology or want to kind of go over these lectures again, these will be recorded. So you can always go back and review today's lecture to help you in your clinical practice. And next up, we have Chandler Johnson. She's one of our wonderful medical students, and she will be doing today's case. Chandler?
Awesome. Thank you so much. I hope y'all can see my slides now. So I'll go ahead and start presenting. So I'm Chandler Johnson, and I'm in between my 3rd and 4th years of med school at the AU UGA Medical Partnership Campus. And I'm excited to present the case today that's courtesy of Dr. Buchanan. So I'll go ahead and jump right into it. So for our case, we have a 67-year-old white male who presented to the dermatology clinic upon referral from his primary care physician over concerns of a red, itchy rash that he had for at least 4 weeks when he presented. The patient described that his rash first began on his right upper back around the size of a baseball, and it had been expanding ever since he had noticed it. Of note, the patient had recently visited his daughter in Rhode Island and had spent some time visiting her there. But unfortunately, he had COVID at least a week before developing the rash. So when he presented to the clinic, we were able to appreciate this erythematous patch that spanned the patient's right upper and lower back, as well as his right flank, a little bit of involvement around his right axilla, and then his right upper chest. We can see that this erythematous patch has an even more well-demarcated border that's quite erythematous. That really speaks to the expanding nature of his rash. And on palpation of the patient's back and chest, there was no induration. However, it was blanchable. There were no appreciable vesicles or bullae or other secondary skin changes. So next, in terms of approaching the patient's rash, we wanted to keep the differential quite large. One of the first differentials that came to mind was tinea incognito, which is a dermatophyte infection where the rash may seem a little bit masked based on a patient potentially using a topical corticosteroid that has immunomodulatory effects. So an example of what tinea incognito would look like potentially is right here. So you can see this background erythematous, potentially even hyperpigmented patch with overlying dark red papules potentially, if you could feel the lesion on physical exam. One of the other differentials that came to mind, especially given the patient's recent travel to an area endemic for Lyme disease, Rhode Island, was chronic erythema migrans. So this is one of the classic images associated with that skin finding. You see this annular rash. However, another example may look more like the photo here to the right, where you can see sort of this erythematous patch of skin, kind of similar to the patient's presentation. Next on the differential list was contact dermatitis, particularly since this patient's skin findings were so well demarcated. Dr. Buchanan was very careful to ask about potential exposures, maybe if the patient was like laying on their left side and sun tanning outside during the summer, but the patient denied any activity such as that. He also denied any use of new topicals or skin products or detergents. So that ruled down a little bit the contact dermatitis. Next on the list was morphia, maybe an early presentation. Next was erythrasma, potentially a drug-induced exanthem. However, the patient did not endorse starting any new medications besides their medication regimen that they had been on for a long time before they had developed this rash. And then finally, potentially a viral exanthem, potentially Lyme disease or COVID, because he had just had that a short time before developing his rash. So in terms of the next steps for working up this patient, KOH scraping was done in the office. It was negative, but the scraping was done out of an abundance of, not caution, but curiosity, given that the fact that the patient did not have any scale, but the origin of this rash was unknown at the time. The patient was concerned about potentially having Lyme disease. He didn't think that he had received a tick bite, but he couldn't be sure. So he wanted to proceed with serology, even though that wouldn't be the standard, usually given the cost of that diagnostic test. However, the patient's IgM was negative. So given this clinical presentation, I would like to take a moment to pause to let you all consider like the potential most likely diagnosis. And now I'll review a few clues that are most useful in helping us narrow down. So first is the fact that this patient presented with this unilateral expanding erythema. Next is the fact that the rash was periflexural, so we had the sparing of the axilla. And then lastly, the fact that this rash developed weeks after COVID. So given those findings, this patient's presentation was most likely representative of a unilateral laterothoracic exanthem. This is also referred to as an asymmetric periflexural exanthem. So this particular pathology is most well documented in the pediatric population, particularly after a patient may have had a viral illness such as parainfluenza virus 2 or 3, adenovirus, human herpes virus 6 or 7, or even Epstein-Barr virus. But here for our patient, he had exposure to COVID. So given this patient's diagnosis, this is a clinical diagnosis, the next step in the treatment plan was first and foremost reassurance that his rash would resolve with time, and we would just observe him. And sure enough, 4 weeks later, the rash did resolve. So based on the fact that this is most well documented in pediatric population, it's important to consider a few cases where this asymmetric periflexural exanthem occurred in adults. So I have 3 short little cases to reinforce the different presentations. So for this first case, this was a 2003 case study based out of India, where a 25-year-old male had initially had a prodromal viral type illness where he had cough, coryza, and also fever. And then 15 days after he had that viral prodrome, he had this sudden eruption of a macular papular rash. Again, this was not bilateral, this was unilateral. You can see over in the image to the left that this rash was localized in the area around his left axilla, right here on the flexural aspect of his right upper arm, and then on his left popliteal space. So this patient was treated with antihistamines and observed over the course of a week, where his rash steadily improved and then it completely resolved after 3 weeks. For the next case, this is a case study from Tunisia in 2020, and a 30-year-old female, similarly to the previous patient, had a viral prodrome where she experienced malaise and rhinorrhea, and then had a sudden eruption of this erythematous patch. And like the previous patient I discussed, she was treated with antihistamines, and then over the course of 3 weeks, her rash improved markedly. And then a final case to discuss, this is a case report of a 30-year-old female in India, and this was in 2022. And she did actually not have a prodrome, but she did have this sudden onset of this erythematous patch. And she was again prescribed antihistamines, and then 3 weeks later, her rash improved markedly. So for our teaching points for this case, first, asymmetric periflexural exanthem is most commonly reported in children, but it can occur in adults, as we see here. And the clinical recognition can prevent further workup, such as serology or even biopsy, which would not have been diagnostic in this case. And then lastly, if you have a patient who's presenting with this unilateral laterothoracic exanthem, consider exposures to viral infections, and they may go hand in hand. Okay. Any questions? I can stop sharing too.
Does anyone have any questions for Chandler or Dr. Newsome? I think that was a great case. Chandler, you did an excellent job. And I think, again, kind of the overarching theme today is just clinical recognition. Dr. Davis always used to teach us that you sort of have to be a detective in this. You have to ask the questions. And so I think this case was really key because, other than the serology for Lyme disease, this patient could be reassured, and we didn't have to do any further workup like a biopsy or potentially, any other outside referrals. So just remember that you have the tools you need most of the time. I know a lot of us don't always have access to do a KOH scraping in clinic, but if you have it, that can also be very helpful. Do you have anything that you would like to add, Dr. Davis or Dr. Rabinovitz?
I have a few things. One, I think anticipating problems is big. So I've been encouraging all of my patients who are 50 and over to get the zoster vaccination, especially prior to starting any of our biologics. I mean, you can't turn on the TV right now without hearing about all our great psoriasis drugs that we have. And so those folks are at a little increased risk of getting shingles. So before you start, I tell people, go get your shingles vaccination before we go there. With dupilumab, which is our new drug for eczema, atopic dermatitis, it clearly states you're at increased risk for having herpes outbreaks. Educate patients. They might even need suppressive therapy so they don't have frequent outbreaks, and tell them to be careful. Don't catch herpes if you're going to be on these drugs. So I think, really educating patients, thinking ahead of time about these viral issues is a big deal. And then I was just going to say, with gabapentin for zoster, in my older patients who are at more increased risk, sometimes I'll just go ahead and start them in gabapentin when they have their shingles outbreak, rather than waiting for them to have pain. It's easier to stop it. That's wonderful. We celebrate if they don't get it, but it's a lot easier to start it the day that you see them. Say, this can get bad. I always rate their pain on 0 to 10, because I'll offer it to them and they'll say, "Oh, I'm fine." And so, well, how bad is your pain? Well, it's an 8 out of 10 today, but I'll be okay. And that doesn't always happen. So I think anticipating the fact that people with shingles are going to have pain, and gabapentin earlier rather than later, I think is helpful. Starting the shingles vaccination the minute you turn 50 is probably a good idea. And then, things like this dupilumab and some of the other competing drugs, you have to be careful with herpes.
I think Maisha has a question. Maisha?
Oh. No, I
see a hand raised, but
No, it's not Android.
It's not what it is.
No, but we have some questions in the chat box.
Yes. Yeah, there's a question in the chat. Mackenzie, with hand, foot, and mouth, does the rash present simultaneously in all areas, or does one area tend to precede another?
Dr. Davis, correct me if I'm wrong, but my understanding is that there's not a specific area that's known to precede the others. I think the important point is just that they don't have to have all three. So if you have characteristic lesions on the palms and soles, but not in the mouth, you would still be thinking hand, foot, and mouth. Is that correct?
Yeah, I think that's true. Yeah. And we have seen it in adults, young parents too. So you just have to have a high index of suspicion.
I have a question actually. With any of these rashes, do they leave scarring, or do they all really ultimately go away and there's no evidence that you had it over time?
So go ahead, Dr. Davis. I'm sorry.
No, you go ahead.
Well, I was going to say, well, as usual, correct me if I'm wrong, but I don't believe any of these would leave scarring, but it is important to note, especially for things like molluscum, one of the reasons that we really strive to reassure parents that treatment is not necessary is some of the treatments might leave marks or scarring more than the actual virus. So if you were to do cryotherapy and you were a little heavy-handed with it, you could have a white mark there, either semi-permanently or permanently. So, but the viral rashes themselves, I don't think I went over any today that would leave scarring. Is that right?
Well, I would just say sometimes the molluscums leave little indentations in the skin that I think go away over time, and I think you're exactly right. You don't want the treatment to be worse than the disease. And so even though you might have a little dimple in the skin, I don't think that you find that years down the road. I think those fade. And the only exception, we're talking about would be shingles. I mean, herpes zoster can definitely leave scarring. But it's not childhood exanthems don't.
Yeah, and I think too, in our patients with darker skin types, it is really important to counsel that you can have a lot of post-inflammatory change, but the rash itself will often be resolved, but you can still see darker or lighter areas of skin coloration that can take, in fact, years to improve.
I think that's a really key point, because a lot of folks will say, but look at my scars. And it takes a lot of education to tell them that those are not scars. The skin has healed either too light or too dark, but given time, that will fade away. So I'm always correcting them and saying, no, you don't use that word. That's not a good word when it comes to, feeling good about things getting better over time. Good discussion.
Okay. If there are no more, are there any other questions or comments? Okay, then I really want to thank both Dr. Newsome and Chandler for great presentations. And I'm not a dermatologist or anything, so it was very educational for me. If we can we have the slides again for so the next session will be on November 6th, and the didactic presentation will be by Dr. Davis Diamond, who has previously spoken to us. He's one of the residents, and he will talk about skin cancer in skin of color, which I know is a very relevant topic for many of the clinics that we have. And there'll be a case presentation by Nicole Nicholas, one of our MCG medical students. And for CME credit, the code is here. It's posted in the chat. You'll get an email about it. And so unless there are any other comments, I think it is just about time to close. I will remind our participating clinics to keep sending your consults into Dr. Buchanan. She's waiting for them. And thank you all for attending. And any of our guests can all feel free to sign off. And a reminder just to our hub team to stay on for a couple more minutes.
Thank you for having me.
Thank you.
Great job.
Thank you.